I will be discussing a few points about how we can improve patient outcomes in emergency surgery. Um, so, just to reiterate the importance of this topic, it has been noted at the most recent national audit project that was done in UK at the end of last year that the population now undergoing anesthesia is at a higher risk of complications than it was a decade ago because the patients are older and obese and having more comorbidities. And the proportion of patients who are fit and well are less. And those with severe comorbidities, such as patients in ASA3 or ASA4 categories, have now gone up. And of course, most of the complications that have occurred over that decade has occurred in high risk settings, mainly urgent and immediate priority surgeries. That is why it is very important for us to optimize these patients, to minimize these complications, and to give a good outcome for our patients. So, through this lecture, I will be discussing or introducing you to types of emergency surgeries and talk about a few challenges and issues faced during emergency surgery as anesthetists and what we can do to improve outcomes in these patients. And also, I would like to introduce the use of early warning scores in our surgical patients. So a recent news chart has been introduced by the Ministry of Health. So I'll be going through that a little and how we can then prepare our patients for surgery and talk a little about anesthetic management. So when it comes to emergency surgeries, uh, when we classify emergencies, surgeries can there can be immediate need for surgery. So that means those patients need to be rushed into theater within minutes. Surgery has to be done to save the life or limb. So any kind of resuscitation done in that case occurs simultaneously with the surgical intervention. Those type of surgeries usually are when it comes to a ruptured aortic aneurysm or some major trauma cases where there is significant bleeding. Then other surgeries that we commonly face as emergencies are urgent surgeries. So these patients are deteriorating because of certain life-threatening conditions, and their life and their organ survival is at imminent risk. So these patients need an intervention within hours usually. So there is a small window of time for us to do some type of resuscitation. Um, that would be certain patients like somebody with the acute abdomen or some critical limb ischemia. Then expedited surgeries. These patients need early intervention, but that the problem they need intervening for is not an immediate threat to the life or limb or organ. So those patients usually may have we have like tendon injuries or maybe cancers. So they might need to have surgery within a few days. So these patients, of course, can be optimized to a certain extent. So, emergency surgeries can range from very minor surgeries, maybe a wound toilet, and maybe something very major like acute abdomen or ruptured aortic aneurysm. And you can see they present for general surgery. The patients can be for general surgery in orthopedics, vascular, neurosurgery, obs and gynae, and even ENT. So there are lots of different types of surgeries, lots of different types of patients ranging from ASA1 to ASA4. So there's a lot of, I suppose, stress on the anesthetist to manage all these different types of patients. So so obviously it's not difficult to realize that anesthesia in emergency surgery is a challenge. So these patients, most often than not, they come with life-threatening conditions, and also there is a limited time for patient optimization, and usually all of these surgeries happen out of hours. So there might be less staff, less expertise, and more stress on the staff that is there. So it's very important that we do a focused pre-anesthetic assessment to see how the patient is, and we need to evaluate the anesthetic risk. That is very important. So we need to identify whether patients are at high risk of post-operative complications. So that's why we need to do the proper history examination and necessary investigations. Uh, but keeping in mind, we don't have a lot of time, so we can't take hours and hours or maybe days to optimize the patients and do all of the investigation. So it has to be focused. And with the risk assessment, it's important to note, to discuss with seniors and to document these risks and to have a proper plan for the perioperative care of the patient. So that includes what type of anesthesia we are going to go for and whether this patient may need post-operative care in a HDU or ICU setting. So, when it comes to specific issues that emergency surgery patients will face, so these patients usually have a high aspiration risk. So, one thing is they might not be adequately fasted. So, as we know, the recommendation is for a patient to be at least fasting for solids for 6 hours and clear fluids for 2 hours. But these patients may be presenting without being adequately fasted. Apart from that, there can be a problem of delayed gastric emptying. Even if the patient has been not taking orally for some time, these patients may be having problems like bowel obstruction or sepsis and related stress. So they might actually have delayed gastric emptying, which presents a high aspiration risk. Then these patients usually are not having an optimal fluid status. Some of them have been fasting for a long time, and also sometimes because of conditions like sepsis or inflammation, there might be increased vascular permeability, leaky capillaries. So they tend to they tend to leak out, and that also can cause a hypovolemia. Then also a lot of them, because of this dehydration, vomiting, diarrhea, all of these things, electrolyte derangements can also be there, which may lead to intraoperative complications. And a lot of these patients come when they are confused. They might be drowsy. So this level of consciousness is a problem for us. We need to think about whether they can maintain the airway, whether if we need to give a GA, can we extubate them? And then, of course, can we take consent? Can we explain the risk to the patient? How are we going to do that? So those are problems, few specific problems that we have to think about when we are faced with a patient coming for emergency surgery. So just to go through a case scenario. So I know, I mean, as anesthetist, we see this all the time. These type of patients always come to us for our casualty list. So just going through a case scenario just to see what the situation is and just to discuss some points. Let's think about one surgical patient coming. He's a male patient, Mr. Pereira, 60 years old. So he has some comorbidities. He's diabetic, having hypertension, and he has an infected wound on the foot, and he has got admitted to a surgical ward, and he's being assessed. So at presentation, he's having a mild tachycardia, 100 beats per minute, marginal pressures. He's breathing at a rate of 20 per minute and maintaining saturations of 97 on room air. So this patient is also febrile and drowsy. So typical ill patient. He has been seen by the house officer, started on some saline and IV antibiotics, and he is awaiting review by the senior house officer, and blood has been sent for investigations. So now the patient is waiting in the ward. That usually happens. So now a couple of hours have gone, and the nurses now have noticed that the patient is not doing well. He has got a little dyspneic. His now respiratory rate has increased 30 breaths per minute, and the on-air saturation has dropped to 93. The blood pressure is also dropping further, and his tachycardia is becoming worse. And the patient is now only responding to pain. So the house officer has called his SHO, who has advised to give a bolus of 500 mLs of normal saline and start some oxygen. And the patient now has been moved to the acute side bed. They have catheterized and started input-output monitoring as well. So then now the patient was admitted at 9 in the morning. Now it's 2 in the afternoon. SHO has come to see and has found that now the investigations are revealing that there is an acute kidney injury, creatinines have gone up, and there is a high WBC count. So he was started on some more IV fluids, but it's only a rate of 100 per minute, 100 per hour. They have given some insulin as well and decided now that this patient should go for urgent surgery in the evening casualty list. And the patient has now at 6 o'clock in the evening come to the casualty theatre. Now we are faced with this patient. So in the theatre, the anesthetist has seen that the patient is having a blood pressure of 90 by 45. He's quite tachycardic now and saturation is 95 on oxygen via face mask and a non-rebreathing bag. And he's tachypneic and GCS is 13. So the anesthetist had given some more fluid boluses and has decided that we'll proceed with a low dose unilateral spinal anesthesia for this procedure. But intraoperatively, after the spinal, the blood pressure has dropped further. And after giving some ephedrine boluses, because the blood pressure was not picking up, they have discussed with seniors and started a NORAD infusion with a neck cannula. Urine output now is not there. So then after the surgery was fast, it was done very quickly. The patient was then brought to recovery and he was okay with the pressures wise with a very small dose of noradrenaline. So they have decided this patient can be managed in the acute side in the surgical ward. So send back to the surgical ward. But unfortunately, in the night round, the patient was found to be gasping. And then at that point, the emergency team has been called. So the patient was intubated and rushed to the ICU. And then at the ICU, they have started from NORAD to vasopressin, escalated the vasopressor support. He had needed CRRT, but unfortunately passed away in the ICU due to multi-organ failure on the background of septic shock. So this is not an uncommon scenario. So could Mr. Pereira have had a better outcome? That is the question that I will, or we will try to answer in this presentation. So how should we improve outcomes for patients presenting for emergency surgery? So these are the recommendations that are given by the emergency laparotomy pathway quality improvement care UK. So that of course I think is applicable to most of the patients who are coming for emergency surgery. So it's very important to assess patients early and adequately resuscitate. This is where the recommendation for the early warning scores come in. So Muse charts will help us to accurately identify where the patient is when it comes to the physiological parameters and whether and to how which extent we need to intervene. And then, of course, they also recommend that whenever possible, if the patient is significantly ill, we can measure lactates. Arterial blood gas measurements are important. And we can measure lactate and use that to guide our resuscitation, especially fluid resuscitation. Then early antibiotics is another important point. So Mr. Pereira may have benefited if he was properly assessed using some kind of early warning score. And I mean, even on admission, he was tachycardic and not doing well. So at that point, maybe if we measured the lactate and found that he is acidotic with high lactates and given some adequate fluid resuscitation, the outcome may have been different. Then early antibiotics, of course, had been started. So that was a good thing for him. So that is also a recommendation. If we are suspecting sepsis, it needs to be within the first hour. Or if there is any evidence of acute abdomen with possible soiling into the abdomen, antibiotics should be started within 3 hours. And patients need to go for early surgery if there is a diagnosis and indication for surgery. So we need to do the relevant investigations, not all investigations, and especially if it is suspected that there's an acute abdomen, CT scan is recommended, and we can then decide uh, to go for early surgery. And once the decision is made, it is recommended that the patient should be taken to theater and the surgery should be done within, ideally within 6 hours, at least within 6 hours, ideally within two. Then goal directed fluid therapy is very important. So it is not to underhydrate or overhydrate. It has to be adequately hydrated, and this needs to continue up to 6 hours post-operative. And the post-operative care also needs to be discussed and we have to plan. So that is why risk assessment is important in the beginning. If the patient is elderly, having comorbidities, and you can use, there are multiple scoring systems that can be discussed with senior consultant input. And then we can decide whether this patient needs post-operative IHD or ICU care. So just to highlight the importance of detecting this clinical deterioration early, so there is this thing called the slippery slope of clinical deterioration. So as you can see, this is the patient's normal level, that is the pre-morbid level. So sometimes for whatever reason, some kind of insult will happen, infection or trauma, and the patient slowly starts to deteriorate. This deterioration initially is a bit slow because the patient is having some reserves, so he can tolerate that insult. But with time, the reserves will get exhausted, and at that point, the deterioration becomes very rapid. So, with a Muse chart or some kind of early warning system, what we can try to do is to detect the deterioration at somewhere around this point. If we do that and we intervene appropriately, we can possibly get the patient back to their usual pre-morbid level. But if we miss that chance, like we that Mr. Pereira, what happened to Mr. Pereira, he was at this point when he was admitted. He slowly, I mean, he then gradually within the next few hours of admission went down the slope, and then the next few days proceeded to uh, loss of life. So if the intervention doesn't happen appropriately, then it's very difficult to get the patient back to pre-morbid level. So maybe even if they survive, they are going to have significant comorbidities. Significant morbidity. So this is the new early warning score chart that has been introduced by the ministry. So it is a requirement now. So there's an H number and circular that has been issued. So the reason that this has been done is the College of Anesthetists and in association with other colleges like surgeons have realized, or it is now accepted worldwide, that the use of early warning scores can significantly improve patient outcomes. So that's why we want to establish the use in Sri Lanka as well. So why early warning scores? So the main reason we go for early warning scores is because when it comes to critical illness, it doesn't matter what the illness is. It could be sepsis, it could be trauma, whatever the reason, the deterioration will be the same, or the signs, the clinical signs of deterioration are the same for every patient. So they reflect drop in the respiratory, cardiovascular, and neurological parameters. So that's why they are the vital signs. So we monitor these vital signs and we can identify clinical deterioration. So the vital signs usually are the commonly measured blood pressure, pulse rate, respiratory rate, and temperature. So the reason that we have created early warning scores is so that the patients or the process is standardized. I mean, there are different types of scoring systems, even in NHSL. There are certain wards, they may have different early warning scores that they use in the ward to monitor patients. But if we have a standard system for the whole of Sri Lanka, then this process becomes a lot easier. And the discussion about patients using this early warning score system also becomes more uniform, because then we know when we are handing over a patient from NHSL ward, surgical ward to the ICU doctors will know what they are talking about. And then when you're transferring a patient, say from NHSL to Colombo South Hospital, again we can use the same Mu score to discuss about the patient's clinical status. So like I said, there are many benefits of early warning scoring system. So the system is now standardized and we can detect acutely unwell patients early. And also, it's not just detecting the unwell patient, there is also guidance for what we are supposed to do when we detect this deterioration. And also, the communication becomes more standard and easy because we are all using a common language. But of course, as for any good thing, there are some limitations. These scores are designed only for adults, the Mu score. There is a Mu score that has been designed for pregnant women. That is a separate chart. That is not for, you can't use this Mu score for pregnant women, because the parameters, we are monitoring the same parameters, but the ranges are different. So that's why. And even in certain special patient groups like high spinal cord injury patients, there may be a few issues when you use the Mu score, because their heart rates, their blood pressure fluctuations may be not like a normal person, but still you can use the Mu score with senior input to monitor the basically the monitor them over a period of time. So where and when to use the Muse chart? The Muse chart should be available for casualty wards and ETUs. So when patients are coming from ETUs and casualty wards, they should have a Muse chart and they should have been monitored. Then surgical wards and medical wards and other specialty wards, any deteriorating patient needs to have a Muse chart. Also, in ICUs and HDUs, ideally, the admission should be after doing a Mu scope and deciding that this patient needs ICU admission. And also, when patients are discharged from ICUs and HDUs, we have to start a Muse chart and start monitoring and send to the ward so that the patient can be assessed in the ward as well. And then, if necessary, outreach team can come and see the patient and decide whether any more interventions are necessary. Then, of course, are surgical patients. So, ideally, all the patients coming out of theatre should have a Muse chart and they should start monitoring on the Muse chart. So, this is the Muse chart. So, the main way that the Muse chart is used is we track and trigger. So we track the patient's physiological parameters like respiratory rate and blood pressure, and there is a record of the patient's physiological status over time. And depending and we track this and we give a score for each parameter. And then depending on that score, the total score, there is a trigger. So if the score is a certain number, then we have to do a certain action. So that is how the Muse chart is used. So this is the observation chart part of the Muse. So there are 6 physiological parameters that we monitor: the respiratory rate, oxygen saturation, pulse rate, systolic blood pressure, level of consciousness, and temperature. So a score is given for each of these parameters. And finally, you calculate a total Mu score for a given time. So for a given time, you have a Mu score here. And at the bottom of that chart, there's some additional monitoring also. Depending on whether the patient needs to be monitored, the doctors can decide and say, Okay, you need to monitor the blood loss or the urine output for this patient, and then also escalation needs to be marked. Anything that you need to add can be added here. And ideally, it's if the nursing officer who's doing the muse can put the name here. Then if there are any issues like if you want to discuss with that particular person who marked the chart about any other things or any clarifications, then it will be easy. That is why not that we want to catch people out. So when it comes to scoring, you notice this white color strip in the middle or on the top. So this white color set of boxes will denote the normal range. So that is what is there in a patient who is normal. So at that point, the score will be 0. So anyone having a respiratory rate of between 12 and 20 will have a 0 mu score. So that is to show the normal range. And then there are these colored boxes, green, amber, and red. So that is to show a gradual deviation from the normal range. So measures outside the normal range are given a number, a value, depending on how bad the deviation is. So in this example, saturation, if it is 94 to 95%, then it's in the green range and they are given one score. If it is 91 to 93, then 2. But if it is less than 90, then that's a red score. So that's 3. 3 points given for that deterioration. And then if there is a red score value of 3, that means there is a significant deterioration in that particular physiological parameter. So that needs to alert us that this patient is really, really ill. So how do we record on the chart? So what is recommended is you put a dot in the square when you measure. So you say that the patient's respiratory rate is 15. So that means it's between 12 and 20. So you put the time and you put a dot here and you mark it like that. Then later, the ward doctors are the ones who decide this. So they will tell the nurse, okay, so this patient can be again assessed in 4 hours time. Or then you have to write the time and do the next measurement. So that time the patient's respiratory rate was 80. That's still in the normal range. So you put a dot here and you connect the dots so that it looks like a graph and the detection it's easy. So how often we need to do this depends on how the patient is doing. So that guidance is also there. I will talk about it in future. So if the patient is doing well, they don't need frequent monitoring. So then you can go for 4 hourly, 6 hourly monitoring. But if the patient is starting to deteriorate, then we need to escalate. So that guidelines are given for how to do that. So that decision has to come after assessment by a doctor. So the nurses will mark and they will escalate saying, all right, now the patient at 5 o'clock, the respiratory rate has gone up. So you mark the dot here and if then you check all the other parameters and depending on the score, then you can inform some senior person and they can decide how the monitoring frequency and what the patient needs next. And ideally, if you are marking a dot in a red square, that means there's a significant physiological derangement. It is recommended that you mark the number. So if this patient suddenly later in the evening developed a respirator of 32, then you mark the dot there and you write the number as well. Because now beyond more than 30, the implications are different if it is 31 or 41. So that is why it is important when it comes to red marking a dot in the red square, it is better to put the number as well so we know how the patient is doing at that time. Then how to calculate the mu score. So you mark all the parameters and you add the score together and you calculate a total score for that given time. And in certain instances, maybe in a peripheral hospital, you may have certain limitations to monitoring. For example, you don't have a pulse oximeter. So then, what are you going to do? Can you not measure Muse? Is there no point? No, you can measure. So even if you don't have oxygen saturation, you can still give scores to the other physiological parameters, and they may have, and they can still give you an idea, and you can still trigger an action depending on that score. But it is always, it is recommended, even if you trigger for that score, you have to write in your remarks that this is an incomplete score. So now we calculate the total mu score. And after calculating the total mu score, you can assess the risk of the patient and decide how you are going to trigger the action, what action needs to be triggered. So if the patient is getting physiological parameters all within the normal range, then obviously the total score will be 0. So those patients may not need significant monitoring. Frequent monitoring. But then some patients may get a score between 1 and 4. They go into the low risk category. Any patient having a single reading of 3 goes into the low medium risk category, even if the score is low. And if the score is 5 or more, then they are in the medium risk category. 7 or more, those patients are the really bad patients, high risk. So what do we do? What is recommended? So this is for clinically deteriorating patients, generally coming to casualty wards, medical wards. These are the recommendations for monitoring for those patients. So in a surgical ward or a medical ward, if the patient is, the mu score will have the urgency of the response will depend on the total mu score, and the frequency of the monitoring also is mentioned, and the clinical response also mentioned. So when it comes to total score of 0, then maybe the patient needs infrequent monitoring, 6 hours, 8 hours, something like that. But if the total score is between 1 and 4, then you might have to escalate the frequency of monitoring. So this depends on a review by the senior doctor, by a doctor or a senior person in the ward. So if the patient is scoring at low risk, then at that point, the person who does the Muse chart has to then inform that there is this score. What am I going to do? When am I going to monitor next? So this patient needs to be reviewed ideally by a doctor within 1 hour's time to decide on the next management plan. If a patient is having a score of 3 in a single parameter, that means that is a significant derangement. That person needs to be urgently reviewed by a doctor, and they need at least hourly monitoring. Then total 5 or more, again hourly monitoring, and needs urgent review by somebody who is senior, possibly a consultant. And 7 or more needs continuous monitoring, and these patients are the ones who ideally need ICU or HDU care. When it comes to our surgical patients, this is the recommendation for monitoring frequency for surgical patients. So if a patient is going out of theater in the first hour, every 15 minutes they need to be monitored. Then in the next hour, that can be downgraded to 30 minutes, provided that the patient is not deteriorating. Then in the next 24 hours, they can be monitored 4 hourly. And if the patient needs to be monitored for more than 24 hours, that decision should come with senior input, and they can decide the frequency of monitoring. Then when transferring a patient out of the ICU as well, we should start a Muse chart, and ideally 2 sets of observations needs to be entered before the patient can go to the ward, so that we can see the trend. Then when it comes to higher scores, if the patient is having a 1 red score, or if the total score is 5 or more, then it is important that we think about sepsis. As we know, sepsis actually is one of the highest causes of death worldwide. It actually causes more deaths than cancer globally. This is according to the latest Sepsis UK data. So if a patient is having red flag criteria, so in the UK, it's the Muse 2 score. So we have the same score for our Muse charts. If the Muse score is 7 or above, then there is a high risk of sepsis, and you need to start managing this patient for sepsis. So this is in a patient with a background of a possible sepsis. So this is not relevant for maybe trauma patients, but any patient who is possibly having some kind of an infection or presenting with some background that is suggestive of sepsis, then you need to assess this patient urgently and think about whether you need to start management for sepsis. Um, if the score is 7 or above, or if the mu score is 5, like I said earlier, and there are uh, any of these significant signs. So if there is mottled or ashy skin, or if there is some kind of a non-blanching rash, there is some cyanosis, or if the patient is deteriorating, since the last assessment or after some kind of an intervention, or if we have at any point monitored lactate and it is more than 2, or there is a recent development of acute kidney injury, then it is highly likely that this patient is having sepsis, and we need to think about that, and we need to urgently initiate treatment. The reason for this, why are we so worried about this sepsis and whether the patient is having sepsis or not? It has been found that delivering these measures or the sepsis 6, starting the sepsis 6 management protocol within 1 hour of detecting or suspecting sepsis, it is the most effective life-saving treatment in one of the most effective life-saving treatments in medicine. That's why we are highlighting this with the MuScore. And that is the reason that this think sepsis part has been added to the MuScore. So these are the sepsis 6. So what we need to do is, if we think, is it possible that this patient is having sepsis? Then that patient needs to be seen by a senior clinician, because sepsis is not a simple thing. It's a complex condition, and you need an experienced person to assess the patient properly and deliver the correct care and to confirm the diagnosis, whether this is actually sepsis. Then oxygen is also given if required. So the idea is to maintain saturations of 94 to 98 in a patient who, say, is not having some kind of a lung pathology test, like COPD patients. Those kind of patients, you can go for a lower saturation, but generally patients, we should target saturations between 94 and 98. The reason is, now usually if there is a septic patient, we find that there is some kind of a imbalance between the oxygen supply and the demand from the body. So if we can give some extra support with oxygen, that will help with the reduction in tissue hypoxia. That is why oxygen will help in these patients. Then we need to urgently obtain good IV access and take blood and send for investigations. It is very important to send for cultures, and also ideally to do a lactate measurement. Then other investigations are also important, like whole blood count. You can check the white cells, urea and electrolytes, any kind of other coagulation screen. And depending on the patient, you might have to consider other investigations as well for the septic screen. Then, after taking cultures, it is important to start within 1 hour. You have to give IV antibiotics and think about source control. So, you should give the maximum dose of broad spectrum therapy. This is after considering any kind of allergies or other hospital guidelines. You can get microbiology opinion and go for the best possible antibiotic cover. Then IV fluids. So these patients are hypovolemic usually, because they are vasodilated for one thing, and they are leaking. So they are intravascularly depleted, and you have to give adequate fluids to maintain circulation and perfusion to the vital organs. So you can go for high doses of fluids, but keep in mind goal directed. So even though sepsis 6 says that you can give up to 20, even some say 30 ml per kg of fluid, it should be done in divided boluses, not all together. And if there needs to be more fluids, or if the patient looks like they are still not resuscitated enough fluid wise, always get senior opinion before you go for more fluids. And lactate is a very useful measure to guide our fluid therapy. Then, of course, important part at the end, monitoring. So we can use the Muse chart to monitor these septic patients. So now we have discussed the Muse monitoring, resuscitation, starting antibiotics, thinking about sepsis. So now these patients are now coming for emergency surgery. What are we going to do? So when a patient comes to you for emergency surgery, or if you are informed that the patient is there for emergency surgery, can you please come and see? This is what we need to do, a quick assessment to see how the patient is doing. So our anesthetic assessment should be focused. So we need to check on patients' comorbidities, mainly focused on the cardiopulmonary system, whatever comorbidities that they have and the severity. So if the patient is hypertensive, is it looking like that patient has poor control, any evidence of heart failure? Those things need to be assessed. And some idea about the functional capacity of the patient, and of course, any drugs they are on, allergies or and fasting status. Examination, important to assess the cardiopulmonary systems, lungs, heart, and also don't forget an airway assessment via anesthetists. We need to know whether the intubation or airway management is going to need help, and relevant investigations. So minor surgeries in patients who are presenting, who are ASA1 or ASA2 with the good control, they may not need many investigations, especially if they are possibly a full blood count and ECG should be fine. But if the patient is going for moderate risk or high risk surgery, and if the patient, even for a minor surgery in a patient who is ASA 3 or 4, then of course you may need to go for most investigations like a full blood count, ECG, and also urea electrolytes, creatinine, and possibly even measure the lactate levels. Then we need to optimize the patients, but keep in mind our resuscitation and optimization cannot delay access to surgery. So we need to think about that when we ask for investigation. So asking for things like 2D echoes for elderly patients, we have to consider what are we going to gain from having a 2D echo. So we can always think, okay, this patient is possibly having heart failure, and manage our anesthetic accordingly rather than delaying the surgery to wait for an echocardio. Then goal-directed fluid resuscitation, as I mentioned earlier, and correction of any electrolytes. These patients generally present with electrolyte abnormalities. Elderly patients, hyponatremia is common, and patients might be having acute kidney injury and hyperkalemia. So all of these things you have to assess and start correcting, because they can lead to poor outcomes during surgery. So once we get an idea about how the patient is, the history, the examination and investigations, then we can stratify the risk. Is this patient, depending on what the surgery is, you can decide what is the level of risk. Is the patient high risk for intraoperative complications, intraoperative cardiac events, postoperative pulmonary complications? So for that, it's always good you assess the patient and get senior opinion on where the patient is at risk wise, and then you can plan a anesthetic plan and a post-operative care plan. So in our anesthetic management, always go for regional anesthetics blocks wherever possible. If we can avoid general anesthesia, that is better. But that doesn't mean that general anesthesia is contraindicated for emergency surgery. Most emergency surgeries will have general anesthetic. And in that case, most of the time, these patients need a rapid sequence induction, because there is a higher risk of pulmonary aspiration because most of these patients will have delayed gastric emptying. So you have to think about that when we are securing the airway. Then it is very important to maintain a good hemodynamic stability during the induction and intraoperative period both. So during our induction, we should avoid very high pressures and very low pressures. And even in the during the anesthesia, it's important to maintain hemodynamic stability because these patients are acutely ill, they're not doing well, they cannot tolerate fluctuations as well as an ASA1 patient would. So you have to think about that. Then intraoperatively, always think about giving adequate volumes. And these volumes, ideally, so we have to think about temperature regulation as well. Warm fluids are the best. So we should make sure the patient is not going to get hypothermic. Why? Because hypothermia can have adverse outcomes for coagulation, for immunity, for wound healing, and then, of course, the metabolic state of the patient. So temperature regulation is something that we tend to forget most of the time, something we need to think about in our intraoperative plan. When we are ventilating the patients, don't go for large tidal volumes. The recommendations are 4 to 6 ml per kg to avoid damage to the lungs, especially sometimes these patients may be having sepsis and may go into ARDS as well. So something we have to think about. Good analgesia is also very important, intraoperative and postoperative. So have a good plan whenever possible. We can use regional anesthesia to top up our pain relief, even if we go for a GA. And having good pain relief will reduce the surgical stress response, which the patient will benefit from. And also, it has shown that, especially in the post-operative period, having good pain relief will reduce the risk of post-operative pulmonary complications because these patients can cough, clear their secretions, they can take deep breaths. So there's less risk of atelectasis. So these things are important in our anesthetic. It's not just giving the GA and recovering the patient. We have to think about how they are going to do in the post-operative period as well. So considering all this and depending on the risk, how the patient did intraoperatively, the problems the patient has, we can decide where we are going to send the patient for post-operative care. So that concludes my academic part of the presentation. I'll be discussing a few case scenarios at the end. So to summarize, yes, so tidal volumes, ideally 4 to 6 ml per kg to maintain a good minute volume. 10 ml per kg, that is what was used in the past. So we generally do not go for large tidal volumes. We can go for 4 to 6 ml per kg, and we can adjust the rate to maintain minute ventilation accordingly. Just to summarize, emergency surgery patients, they present unique challenges to the anesthetist, and early warning scores are very useful to identify deteriorating patients, and they have shown to improve outcomes. That's why we are trying to implement the early warning score system in Sri Lanka as well. So these systems use a track and trigger system to monitor patients' physiological parameters, and then depending on the scoring system, we can escalate appropriate care. And keep in mind that the Muse chart we are introducing now is for adults 16 years and above. And as anesthetists, we have to see whether this Muse chart is being initiated for our post-op patients and for patients being discharged from the ICU. So it is very important considering the burden that sepsis has worldwide for morbidity and mortality and cost for our healthcare system. We have to always exclude sepsis when we are using the Muse chart. So if there is a possibility, if there is a risk of infection, or if the patient is having a possibility of some kind of pathology that can lead to sepsis, always if the score is there, the relevant score is there. So if there is one red score in any one of the parameters, or if the total score is 5 or more, think sepsis, and you start the sepsis 6. Right. Then Uh, the When it comes to our surgical patients, preoperative preparation includes anesthetic assessment and targeted optimization and risk stratification. And resuscitation should not delay access to surgery. And during surgery, we need to go for at goal-directed fluids, good analgesia, and maintaining good temperature control, and get senior input and plan a good post-operative care plan appropriately depending on how the patient is and our anesthetics and our surgical risk factors. So that is that. So these are my references.